I have the pleasure of talking about a device which is very dear to my heart. It's the DermaLight KTP Laser. Just by way of background, I've been doing laser work now for over 30 years, and I've used almost every machine out there. And you can already see how little this machine is, and yet you'll see how versatile it is and how it's become such a big part of our practice in New York and New Jersey, where I am. And so it is a 532 nanometer green light laser, long pulse laser. It follows the principle that we've all learned over the last 3 decades, and that is selective photothermolysis. You don't need anesthesia. Because of the nature of the technology, there is no post-treatment purpura that we so often see with pulse dye lasers. By using this appropriately, you minimize the risk of post-inflammatory hyperpigmentation. And what it does is it selectively does what photothermolysis is all about. It heats and destroys the target tissue without damaging anything around it. What are the chromophores we're going after? What are the substances absorbing this green light? Hemoglobin and melanin. And therefore, the most common indications, I'll get to some others as well, but the most common indications are vascular lesions, pigmented lesions, and active acne. And if I think about all the things that I treat in my clinics and all the laser technology I've used, without question, probably 85% of what I treat is vascular and pigmented lesions, and then we can also treat active acne as well. Now, when you're using a green light laser such as this one, which is solo absorbed by pigment, you have to start thinking about the Fitzpatrick scale. And sometimes this is a little confusing because this scale was developed in Boston so many years ago. And obviously the world is just not like this 1 through 6. We have so much mixing of skin colors now. There might be 3.5s and 4.5s and 5.5s. Point is, you're not going to use a laser like this, which is so well absorbed by melanin, in people who are very dark. And the fortunate thing about that is people who are very dark, you don't tend to see anything vascular in them, and they don't tend to have a lot of brown spots either. So most of what we treat is sort of type 1 or 2 through 4. So as I said, we treat vascular lesions with the device. We safely treat types 1 through 3, the lighter skin types, and those are the people who present with these vascular lesions anyway. And the energy passes through the skin to selectively be absorbed into the vessel. We can also treat pigmented lesions and pretty much every skin type. But as I said, it's going to be most commonly in the lighter people who get these brown spots. And you can also use this device in the scan mode, where you're using defocus energy. Sometimes we use that for people with broad areas of redness, such as rosacea or even acne. And you always want to avoid tattoos because you're not trying to treat the tattoo, and this actually will thermally heat tattoos up too much. So if you see a tattoo in the area you're treating, avoid it. So when we're treating vascular lesions, we are going to target oxyhemoglobin. And so these are the blood vessels that are directly below the skin. And the common things we treat, and this is garden variety laser aesthetic medicine, are telangiectasies, dilated facial vessels, angiomas, or they're called cherry angiomas, slightly raised red lesions, very common on the trunk, very common in families, and then rosacea, which often is there with telangiectasias, and that's the red facial flushing around the nose and cheeks. Treatment protocol typically is 3, sometimes 4 treatments spaced about a month apart. And so what are we doing and what do we have to think about? And this is how you go from being good to being excellent, is to think not a lot about physics. Physics is overwhelming, it's boring, but just some basic concepts. What's the wavelength? Well, this is 532 nanometers, which seeks out a target, which is the chromophore, and that could be hemoglobin or melanin. What's the power? How much energy is being delivered? Think of it like a light bulb, watts. How big is the spot size? This device, the one I have, comes with 1 and 3 millimeter spot size. The fluence is that power, that's the second bullet, over the area of the spot size. And so take that power, that wattage, and then over the area of the aiming beam, which is 1 to 3 millimeters. How long is the zap? How long is the pulse of energy on the skin, measured in milliseconds? And then what's the interval between each of those pulses? That's the off time. Those are all the things you have to think about. It's 6. Right now, it may be confusing. Once you start using the machine, it is very easy, very quickly. Here's the screen. I mean, it's really pretty simple. You see pigmented lesion at the top, scanning, vascular lesions at the bottom, ready standby, that's self-explanatory. And you see the 532 nanometer, which is green light laser. and then the intervals between the zaps and the pulse duration. How do we treat people? Well, before we treat them, obviously you're going to clean the skin with alcohol. You want to get all that makeup off, any dirt off. You let the area dry. We often pre-cool the area. I mean, there's so many ways to do this. You can use ice packs, cold packs, rolling cold devices, or even Zimmer air cooling. This does provide an analgesic effect, but it also protects the epidermis so it doesn't overheat. And then post-cooling, we do that as well after we treat people. That gets the heat off the area. It's kind of like putting an ice cube on the skin. We often use Vaseline or Aquaphor after treatment, which keeps the skin hydrated. And obviously, whenever you injure the skin with anything you do, whether this laser or anything else, you're going to treat this. You're going to protect that skin from sun exposure. And so we have people use protective clothing and sunblocks. So I talked about the fact that there are a whole variety of indications. I mentioned vascular lesions, pigmented lesions, active acne. Those are our three most common treatments that we use. But you can also use the device for scar revision, improving scars, and even warts, because what are warts? Warts are obviously viral growths, but they're loaded with blood vessels. So we're occluding the blood vessels, and that's how we can improve warts. And what I'm going to show you with each indication is a video with us treating people with these particular entities. There's telangiectasias, very commonly seen in photodamaged skin, often in elderly people, but this is garden variety dermatology, light skin complexions over the age of 40. They show up all the time, and you see the results post-treatment, just so easy to treat. And again, once a month, usually 3-ish sessions. And here's the treatment. And you'll see tracing over the vessel, really bright green light. Don't try this is destroy your skin, which obviously means you have to wait. Look how that vessel's blanching, disappearing. And then it does come back, and then slowly but surely over time, it disappears. So the initial effect is vasoconstriction, and ultimately the body takes it away. There you can see these large vessels on the nose. You know, I grew up with the pulse dye laser. That does not ever work on this, doesn't produce enough heat. And yet, look, with this device, you can see the tremendous improvement. Same thing on the chin. Before and after, and before and after. And these vessels on the sides of the nose, you try to treat these with an IPL, intense pulse light, try to treat them with a pulse dye laser, you're going to fail. Where this laser works so well. Here you see us treating again. That green light. Vascular lesion. Device that is less than 30 seconds. Take it from that far. Treating angiomas. Tell people this is the goal because the age of 30. So angiomas, those little red blobs that probably some of us have. What are we treating? Oxyhemoglobin. And again, a couple treatments. These actually usually don't take 3 to 4. These are usually 2 treatments, sometimes even once. And you can see the improvement. And actually that pulse dye laser does not work on AR vessels on the nose, and it certainly doesn't work. So you see that air quicker there. There's your endpoint. Just pop it off. They just fall off or so. Venous lakes, very common and very easy to treat with this device. Here, there's no anesthesia used, just a little bit of cooling. See the ice pack in the left hand, that's the ice. That's the device, it takes seconds. Plantar warts, I mean, obviously this is not antiviral. In the end, people have to get rid of their warts, but they get rid of their warts by us irritating, annoying their warts. And in the case of using this laser, we're clogging up those vessels. I tell patients essentially by using the laser on their warts and clogging up the vessels, we're putting the warts on a diet. And when you diet them long enough, and they just die. Contrast this just much more doesn't create skin. Here's scars. And so if you have a fully white scar, the laser won't work. Obviously, it's absorbing hemoglobin. But you get a fresh red scar or a hypertrophic scar like this, they can last for months and months. People are bothered by them, and we can easily treat them and get good results. So here you can see a scar here. So I call it little baby KTP laser. Something like acne, a big problem. A lot of people increasingly do not want to take oral agents, so we need something that's going to improve them beyond just their topical agents. How does the laser work? We're reducing papulopustular or inflammatory acne by killing the Propionibacterium acne that cause acne. That's the bacteria there. The heat of this softens and melts the sebum, the oil, and reduces the erythema, the redness, and inflammation. We do more treatments. It's not once a month. This is more like once a week. Occasionally, I do once every other week, and we do generally 4 to 6 weeks and then reevaluate. So you can see this scanning node now. Yeah, mind you, no topical anesthesia. Yeah, he's got goggles. We have goggles. So that's things that are vascular. Now, how about melanin? There's obviously a lot of dark pigment present in skin produced by melanosomes. And the common lesions we treat are lentiginous, so-called age spots. I've learned to tell patients they're experience spots. They prefer to hear that. Seborrheic keratoses, these are sort of the barnacles that people get with time on their trunk usually. And dermatosis papulosis nigrans, which actually are seborrheic keratosis, but they're generally on the face of Asian or African descent, patients of Asian or African descent. Here it's 2 to 3 treatments done about a month apart. So the acne really is once a week, but pretty much everything else we do is about a month apart. And here you can see her being treated. She has lentiginous, age spots. They get a little darker after treatment. They just flake off over the next month. Same thing. Obviously, those are the most common areas. You can see those little brown spots. These are dermatosis papulosis nigrans. These little bumpy things on the face. Really hard to treat, and yet this is so easy to treat them. So here you can see before and after lentiginous on the top, and before and after dermatosis papulosis nigrans, DPNs on the bottom. And look at those great results. We're treating more of these DPNs. And people have so many of them. You treat literally 50, 100 at a time within really minutes. Before, after, dermatosis papulosis nigrans. And so, there are a lot of devices out there. I mean, I've been doing this for a long time. I've used them all. Think about them. Pulse dye laser was really one of the first. Certainly was the device used for children. It's got a toxic dye, requires cryogen, doesn't produce enough heat to treat alar vessels on the sides of the nose or angiomas, which are probably the most common things we treat. Tense pulse light devices generally have very, very big tips to them, hard to treat little areas. 1064 Nd:YAG lasers go too deep for most of what we treat. Electrocautery is what we had before lasers. You just burn the skin and you end up with scars. There were older, smaller systems made by Laserscope called Iridex. They're actually pretty good, but they don't exist anymore. And then Cutera XLV is also a 532 nanometer laser. It's a very big device and very expensive. So here you see some of the older devices on the left. Those are the old KTP lasers. And really this device now has replaced all them. And on the right is the big XLV from Cutera. If you're just starting or you just want to treat little vessels, this is a much smaller, easier device to use, easy to move around, and certainly a lot less expensive. So there it is, the DermaLight KTP laser on the left, and compare that to the XLV on the right. Both 532 nanometer devices. But the XLV laser, if you know anything about it, there have been a lot of problems with the crystals. They break all too commonly. You have to have an expensive service contract. And the KTP laser, the DermaLight system, is just small, easy to use. It's really a great starter device, and it's a great device even if you're an expert. So there is obviously a healing process. You've got the superficial injury that takes several days to heal. You can even get a little bit of crusting. That's okay. And as I said, you have to be careful about sun exposure. Scarring will never be never from any device, so you always have to have a consent form. But when you use this appropriately, there's a very, very, very low risk of scarring. You always want to ask people about their previous history of unfavorable healing, because if they have problems with other things, they may with this. And as long as they treat this appropriately and use appropriate sunscreens, and you're treating all the things we talked about, you're going to have happy patients and you're going to go home happy. And it's fun to do. There's just not much to do with this in terms of service. It's got an advanced generation of handpieces and fibers, which is why it's so stable. And the touchscreen is just really simple to use. It does clearly replace the older technology, as I mentioned. The Iridex laser scope system actually was a nice small system, not made anymore. Pulse dye lasers, most people don't use those. They're used still to treat some little babies with port wine stains, but it's not a mainstream use anymore. And so certainly for the first time laser user, this is affordable, it's easy to use, people are very satisfied, great ROI, but I would argue for those of us who are experienced, and I'm doing this a long time, it is a great adjunct to other things I do. It's got this intuitive color touch screen. It's just so easy to use. It has a wireless foot pedal, which I like. Some of these devices, the foot pedal is connected via wire to the device. And then how do you get from the left side of the table to the right side of the table? You have to move either the device to the other side, which can be big, or you've got to figure out how you kick that pedal with the wire attached to it. This is wireless, which you would think they'd all have at this point. Uses a Windows operating system, which is why it just doesn't break down. As I said, the handpiece is really solid. There are preset protocols, and that's what everybody starts with. You do this for a couple months and you'll forget those because you'll start having some fun with it. It is compact and portable, less than 30 pounds, and it's made in the US. It actually has been endorsed by the associations that I belong to, American Academy of Dermatology and the American Society of Dermatologic Surgery. Published in so many different journals, and even a paper which I was fortunate enough to be on. Affordable New Surge KTP Laser delivers high efficacy and ease of use with some of my colleagues. So there it is, not too complicated, not too much to look at. And think about what I just said. The power is there. You see that on left, that's 1. You see the pulse duration, how long the zap is in the middle. You see the interval between those pulses on the right. Ready, standby. There's not much more to do. And then there's the handpiece. If you want to learn more about this, I did write a book on laser treatment of vascular lesions. You can see the top person with the telangiectasias on the nose, perfect candidate for this device. And then the baby with the port wine stain below that, that's just not what you want to see when you're treating adults. How about questions?
All right, thank you, Dr. Goldberg. That was incredibly informative. We appreciate you taking the time to share your knowledge with us about using the DermaLight KTP for a variety of clinical applications. I'm going to begin Q&A section of the webinar. So if you have not had a chance to submit questions, feel free to continually add them. I'll be monitoring them and running things by Dr. Goldberg as we have time. So jumping right in, one of the first questions was, Dr. Goldberg, will 532 nanometer that wavelength have an impact on collagen?
It's a great question. And so in theory, this is going to be absorbed by hemoglobin and melanin. But in practicality, in the body's destruction of that vessel or melanin, there's a wound created. You don't see it because this is such fine tuning. But in the process of that wound being created, there is new collagen placed. And so if you do biopsies of patients treated with really any vascular lesion, but including this one, and you look at neocollagenesis, it's there. And so where that shows up in using this device is if you treat large areas, lots of lentiginous, lots of vessels, and you ask patients, tell us about your improvement. They're going to say their pigmented lesions, 1 or 2 treatments are better. They're going to say that telangiectasias, 1, 2, 3, occasionally 4, over the course of a month time, they're better. Yet if you ask them at 6 months about the quality of their skin, collagen takes 3 to 6 months to occur. Collagen formation takes 3 to 6 months to occur after the injury. They'll tell you 6 months later their skin looks better than before they started. So that's a long answer to the short question. Yes, collagen is formed.
Thank you. Another question. So, do you worry about aerosolizing HPV when treating warts?
Do I worry about aerosolizing HPV when treating warts? I guess in the pandemic, I've stopped worrying about warts. You worry about other things. I actually don't. I mean, if you wear a mask, which is what we do, um, you know, that virus plume in theory can go through the mask. In practicality, it generally doesn't. That's really much more of a problem, actually, in terms of plume, in terms of treating hair, which we don't use this device for. So, but having said that, when we treat warts, we have that cooler on, but we often have a smoke evacuator as well. And I've again done this 30 years. I've never seen me, my staff, any patient ever have a wart show up somewhere else because we did laser on them.
Thank you. Also, can the KTP laser be delegated to staff?
Can KTP laser be delegated to staff? So some people on this webinar tonight probably know I'm also an attorney. And apparently there's a worldwide crowd on this. So this is going to vary from where you are. You know, the rules, the laws, the regulations for this vary from country to country, and the United States from state to state. And so the answer to the question is you got to find out what the rules are where you live. And I can't give you one answer. I will tell you this laser, where I live in New York, we often delegate it to others.
Thank you. Another question, what is the endpoint that you're looking for when treating in scan mode?
So in scan mode, it's a little bit different than when you're not in scan mode. So when you're not in scan mode, I talked about the angiomas. You're trying to get a little, in essence, a little bit of black and blue there, although we don't usually get that on the face. Lentigines, you want to get a little bit darker. When we're in the scan mode, and I tend to use that for rosacea, I tend to use it for some acne, all I'm trying to do is get a little bit of flushing. And usually if I go over the area a couple times, I get it.
Thank you. Next, do you recommend numbing patients prior to a KTP laser procedure?
Most commonly, we don't. You know, if you saw those ice packs used, you saw that Zimmer air cooler, we generally do not. You know, there's never an absolute to that question. I find that sometimes younger patients need a little numbing. Women, by and large, don't. Okay, you know, occasional guys do, but most commonly we use nothing. It's just an ice pack and nothing more than that. And if I do use numbing, it's going to be some sort of topical numbing cream.
And then along the same terms, a couple questions about using ultrasound gel when treating telangiectasia or some larger vessels.
Yeah, so I mean, ultrasound gel is used with a lot of devices. It initially was used to cool the skin. If you go way back now, 25 years ago, the original IPLs, known as photoderm, or as they were called, photoburn, we use gels all the time to cool the skin. Now that we use ice packs and we use Zimmer coolers, we don't need the gel for cooling. And so the only potential advantage for cooling would be if you have a handpiece that you're dragging on the skin, it allows you to move that handpiece over the skin more easily. That's not an issue with this device. You know, you're not dragging anything. You're either doing that scan mode where, you know, you're not even in contact with the skin, or you're treating isolated lesions where there's no reason to have the cooling gel at all.
Thank you. Also, some questions on, are you able to treat larger vessels? A few questions about treating them on the legs as well with the 532 nanometer wavelength.
Yeah, well, the question is, does any laser work all that well on large vessels on the leg? And you're really talking about varicose veins or venules. You know, sclerotherapy still is the treatment of choice for these larger blue vessels. A lot of those people have also mats and smaller red vessels, and those vessels, this laser works well on. And so I most commonly use a combination of this laser plus sclerotherapy together, because most people have both.
Thank you. And then quite a few questions about rosacea. I know you talked about that a bit, and sort of how to factor in when to use scan mode, when to use the vascular treatment mode. Seems like some questions about targeted vessels versus background redness.
Yeah, and that's a really great question because most people with rosacea have both. And so what I generally do is I do the scan mode first, go over the whole area, and then I go back to the vessels and out of the scan mode and target those vessels. I've done it the other way around, and I'm not sure why, but it doesn't seem to work as well for me.
Thank you. Couple questions. What are the disposables required for this laser?
None that I'm aware of. None. Ice packs, maybe. That's about it.
Perfect. Questions about how long it takes to perform a treatment on average.
It depends what we're treating. Let's take the longest treatment, which to me is generally rosacea or dermatosis papulosis nigrans, because that's involves the better part of the face. I can't remember the last time I spent more than 15 minutes on a face with this device.
Thanks. Questions about treating post-inflammatory erythema from acne. How many sessions to get that under control, and what Fitzpatrick types can we treat?
So think of post-inflammatory erythema in some ways as being like red scars. Obviously it's not, but think of it the same way. So you've got the 532, it is absorbed by hemoglobin. Generally post-inflammatory erythema from acne, which we definitely use the laser for, I'll treat them usually twice, about a month apart. I've done a third time, it's usually twice. In terms of skin types, I mean, erythema shows up most commonly in light-skinned people. So that's usually Fitzpatrick 1 through 4. And I don't know that I've ever used the device to treat post-inflammatory erythema in acne in anybody darker than type 4.
Thank you. Do you have any off-label settings that you find helpful?
So to me, off-label means, do I vary from the sort of the set protocols the company gives me? And the answer is I do all the time. And probably the most common scenario for that is when I'm treating vessels on the nose, I don't want whitening of the skin, but I want to get a blanch. And everybody is different in terms of the pressure of those vessels. And so, use the presets. And then if you're not getting that blanch, then, increase the length of the pulse and play with it a little
bit. Questions maybe comparing to a pulse dye, and do you ever see purpura caused by the KTP wavelength?
I have, outside of treating angiomas where I'm trying to get some purpura, let's cherry angiomas on the trunk, I don't know that I've ever seen purpura from this laser.
Thank you.
Sometimes you get a transient graying of a vessel, which we call transient purpura, but true purpura, which means it lasts for 7 to 10 days, never seen it.
Perfect. Also, how do patients find these treatments to be tolerable?
Yeah, well, that gets back to the numbing question. I think the overwhelming majority of people find this very easy. I mean, compare it to other things like, a lot of us have used electrocautery for vessels. That hurts so much more than this laser does.
Thank you. Also, a couple questions about that erythema caused by the treatment. How long does that typically last, and when will that subside for a patient?
Yeah, most commonly it lasts about a half hour. I've seen it last maybe 2 to 3 hours. I tell patients it's going to be gone by the time they go to sleep.
Thank you. Couple questions. Again, you decide if you feel comfortable answering this about when you're telling a patient to expect 3 treatments 1 month apart. Do you sell that as a package, or are you charging each time for a treatment?
Yeah, it's a really good question. If I truly believe that they're going to need 3 treatments, I want them to do 3 treatments because that means they're going to get the best result. So the way I do that is we will tell them what the price is per treatment. We'll tell them they're going to need 3 treatments, and if they pay for all 3 up front, then we'll give them a small discount.
Thank you. Some additional questions, I guess, about the scan mode are coming in. how can you tell that you're treating aggressively enough? And again, about sort of what is your endpoint for that scan mode?
Yeah, it's the same thing I said before. I mean, you want to get a little bit of flushing. That's really what it is. And then if I'm not getting flushing, then I'll just go over the area twice, but generally get some flushing. Particularly if you think about what the indications are for it, and I most commonly use it for rosacea or for acne. You know, those they have some erythema, some flushing anyway, and so this will bring on that flushing, and then I know I'm done.
Thank you. A couple specific indications. Can you treat sebaceous hyperplasia with the KTP laser?
You actually can. You know, you have to think about what you're doing here, though, because that's not melanin, that's not hemoglobin. Okay, that really is sebaceous material. So there, it's more heat related. It kind of gets back to how we treat acne. Acne has lots of different factors, and so you know, what are the ways you can treat sebaceous hyperplasia? One is you don't have to do anything, but people are really bothered by it. So you can use electrocautery, which burns it. And the problem with burning is they get divots. And so I'll use this laser for sebaceous hyperplasia, and I'll tell them which is factual. I'm not getting rid of all of them. They're going to really flatten down, and I don't have the risk of scarring that I see with electrocautery.
Thank you. Also, questions specific to treating poikiloderma. Does that respond well to the KTP?
It can. It depends. You know, the poikiloderma is complicated. You know, you're treating vascularity, you're treating pigment. Um, Ideally, what you want to do with this device is go after the vascular part first, let that settle down for a couple months, then go after the pigment because you're going to treat it somewhat differently, and your endpoint's going to be different. And so, don't think of treating it all at one time. This is going to be done over time.
Um, any risk of causing vasoconstriction when adding cooling?
Well, sure. If you provide too much cooling, I mean that's the whole point of cooling is take the edge off, and so you apply an ice pack, and then you take it away for whatever 30 seconds, and then then there shouldn't be any vasoconstriction at that point. The vasoconstriction you get is from the laser, and that's good.
Thank you. Also, some questions about, are you seeing any improvement with acne scarring after treatment with the KTP laser?
Well, you are for the same reason that you see better quality skin. You're producing collagen. You know, and I tell patients, look, I'm not getting rid of your scar, but I'm going to create collagen below it. And so you take a deep cave, you treat it with this laser, you produce collagen below it, and the deep cave of the scar becomes a more superficial cave. And I say to them, that means, you know, 6 months, a year later, you're still going to see scars. But when people look at you or in pictures, it looks better. And I explain to them the reason for that is if you build collagen from below, so the cave is not so deep, when light bounces off the depth of it, there's less of a shadow. If there's less of a shadow, then it's less obvious. And I tell them, you know, I give them sort of a scenario that every day, as they all do, every day they look in the mirror and they see their scars, and some days their scars look worse than other days. And how can that be? It's the same darn scar. Well, it's the shadow effect. And so using this laser, if I produce collagen below the skin, the scar will not be as deep, there'll be less of a shadow, and they look better.
Thank you. A couple questions about when treating lesions. Are you treating them sometimes more than one time during each treatment setting, or how are you approaching that?
Well, I'm not sure what is meant by lesions. Whatever I'm treating outside of the scan mode where flushing is my endpoint, when I'm treating lesions, I want to get a little darkening of a lentigo. I want to get a little bit darkening of DPNs, and I want to get a little bit of constriction of the vessels. Well, there's no set number of passes that does that. Sometimes you get it on the first shot. Sometimes you have to do it several times. You know, I don't worry about going over something too many times if I don't get my endpoint, because if I don't get my endpoint, I'm not gonna cook the skin. You know, when do I stop? I'll go over something 3 times and then I'm done, one way or the other.
Thank you. Couple questions comparing the KTP to either IPL or Q-switch laser in terms of its treatment ability on solar lentigines.
So I think of the IPL and KTP in some ways being the same when it comes to lentigines because they're both long pulse systems. As I said earlier, the problem with IPL and treating lentigines is it's hard to get the spot size to fit where you want it. and they're also very big machines and by and large pretty expensive. When you talk about Q-switch lasers, that's a whole different animal, because those lasers, they certainly work for lentiginous and they work well, but they create a wound, because that's also 532, but it's either nanosecond or picosecond, much more expensive systems, a lot of them unstable, and they're going to walk around with scrapes on their face generally a week, 10 days. They will not do that with this.
Thank you. Also, can you treat red acne scars while a patient is on Accutane?
Controversial. If you asked me the question 20 years ago, I would have said no. Now we do it all the time.
Also, question about how long should a patient avoid sun exposure post-treatment?
Well, I'm a dermatologist. I tell them to avoid sun exposure, period. So let's start with that. But post-treatment, generally a week.
Okay, I believe I got through most of the questions. If anybody has any they've been hoping to get answered live with Dr. Goldberg, you can continue to send those in for the next minute or so. If not, we're happy to again answer any questions if you send emails. So it's a question about, is there any plume generated with the KTP?
You know, as the question before, which was such a great question, there really is no plume at all outside of the potential plume when you're treating warts. But the reality is when you're treating warts, you're actually not destroying the warts. You're simply clogging up those vessels. And so there's little to no plume. Having said that, as I said, when we treat warts, we're obviously, I mean, we're wearing masks for everything we do today in the United States. But we do use a smoke evacuator as well when we treat warts, and nothing else because there's no plume.
Question about treating angiokeratomas. How are you seeing results with those?
You can get some improvement, but angiokeratomas by and large don't respond well to anything. So you can lump this laser in there too. If they have a couple of angiokeratomas, and the most common scenario where I see that actually are men, older men on their scrotum, they get angiokeratomas. If they have a couple, I'll treat them and they'll actually do well. But they often come in with hundreds of them, and it's overwhelming. We generally don't treat
them. Question about what is the endpoint when you're treating warts?
The endpoint when you're treating warts, a little bit analogous to when you treat cherry angiomas. You want to get a little black and blue, a little purple in them.
And then I believe you touched on some impacts of collagen, but do you see any skin tightening caused by this laser?
No, 532 nanometers just doesn't go deep enough to really do that. So, you know, expect better quality of skin. This is not a facelift.
Question, can you use this laser to treat ulcerated infantile hemangiomas?
I don't.
And then questions about the glasses. So do you believe there's a specific set of glasses that helps you to better visualize vessels while treating?
Well, I mean, first of all, you're going to use 532 nanometer protective goggles, which for the most part tend to be orange in color. I can see through them pretty well. So I find the only goggles that are really difficult to use are IPL goggles. I think goggles that come with this device, you can see very clearly.
Also, just maybe a Cyrus polarized light might have been something that there was a question about.
So I mean, so Cyrus makes a great polarized light, and there are other devices now also that tend to polarize. That makes it easier to see vessels. But I find that if it's that hard to see the vessel, unless you're using a polarized light, they often don't respond to, frankly, any device. And patients are not complaining about vessels that you see with polarized light. They're complaining about vessels they see and you can see. So, I mean, those are great things to use. Again, their whole Cyrus is one, but they're a bunch of companies now. But for the most part, you don't need them because patients will say, look at the vessels on my nose, treat them, and that's what you treat.
Thank you. Also, are you using numbing when treating plantar warts?
I've tried it. You tend not to go deep enough with numbing creams, so we just put a bunch of ice on them, blow cold air. I don't find the topical numbing creams, even the compounded versions, are very helpful when you treat warts.
Looks like there's a follow-up question. Do you inject with lidocaine ever?
When I treat warts, is that the question?
Yes.
Yeah, I have. But that also hurts. You know, again, there's always exceptions, but for the most part, it's cold air and ice packs. And it goes so quickly, so it's not, you know, remember the numbing medicine hurts in its own way. It takes time. You're not treating those warts for very long. And one point I may add, the most common way to treat warts is with liquid nitrogen by freezing them. This laser hurts less than liquid nitrogen.
And then seems like a couple questions just in regards to blanching of vessels. A few people are saying that they see vessels either go away or they don't. Is blanching transitory?
Initial blanching is your endpoint, but initial blanching does not mean the vessel's gone. And so you want that. I mean, remember I said that you have to treat telangiectasias generally 3-ish times, sometimes 4. Well, if you get a blanch on the initial treatment, does that mean the vessel's gone? The answer is no. That's your endpoint. That doesn't mean it's gone. And so you get vasoconstriction, then it dilates again. And then I tell patients that's going to happen because otherwise they're going to call you when they get home and say, my God, the vessel was gone and it came right back. Well, yes, it did. And that's the endpoint, and that's to be expected.
All right, I think we've reached the end of questions. So yeah, definitely appreciate you joining us tonight, Dr. Goldberg, and hopefully everybody learns a lot about the KTP laser. Again, if anybody has some additional questions, you can email us and we're happy to answer those. But yeah, thank you for everything, Dr. Goldberg. Jen, do you have any
Good night, everybody, or good afternoon, wherever you are. Take care. Bye-bye.
All right, thank you.